Hello, everyone. You're listening to Michelle Speaks on 180radionow.com, currently heard in over 128 countries around the world, and I'm your host, Michelle Portier, founder of Healing Women, Healing Nations of Northeast Florida. We live in a society that condones living behind masks, hiding who we are and the issues we face, some too taboo to discuss with anyone. You may be worried about being judged or ashamed of what others may be thinking of you. Michelle Speaks not only uncovers it, but we look for solutions to deal with it head on. Stay tuned as we get to the heart of the matter, because if you hide it, you can't heal it. Welcome to this week's segment of Michelle Speaks. If you hide it, you can't heal it, where no topic is taboo. This week, we're going to be discussing all about opioids. When is enough enough? When does it become too much? With my very special guest, Mrs. Susan Pitman, founder and executive director of Drug Free Duval. Before we let Mrs. Pitman share a little bit with our listening audience about herself, I want to provide you with a brief synopsis of our topic, all about opiates. Some pain disorders require prescription drug interventions. Other conditions may respond to over-the-counter medications like aspirin or ibuprofen. Still, other conditions may need a combination of both. However, some pain disorders can be effectively treated without any chemical interventions at all. It's important to remember that any psychoactive medication can be problematic for people with a genetic or personal history of addictive disorders. Unfortunately, there may be times when opiate or opioid medication management is needed, but there are risks. It is important to be aware of both the benefits and potential consequences of using opiate medications for chronic pain management. There are arguments for and against opioid use for chronic pain management. So let's get to the heart of the matter so you can make an informed decision for you and your loved ones. So I want to welcome you, Mrs. Susan Pitman. Thank you so much for agreeing to come on and talk about such a sensitive topic.
It's a tough one for sure. Thank you so much for having me, Michelle.
You're welcome.
Really appreciate it.
It's a pleasure. And I know we got into a bit of a conversation before we came on the air, so I kind of want you to touch on everything that we talked about. But before we go any further, can you tell my listening audience, who is Susan Pitman professionally, personally, and spiritually?
Well, thank you for that opportunity. Personally, I'm a daughter, I'm a wife, I'm a mom, I'm a community member, I'm a lifelong learner. Those are kind of incorporates the general kind of personally who I am. Professionally,
right.
I was a banker, then a consultant. Yeah, I've had a consulting firm for over 20 years.
Wow.
I was policy advisor to the Senate president in the state of Florida.
Wow.
And learned a lot about how things are made law. The real behind the scenes stuff, that's a whole nother conversation.
Right.
And I founded Drug Free Duval in 2008 because of a variety of situations that had occurred in our community and addiction in my family and things. And also recently, my husband and I have founded a ministry called Unbounded, which is a marriage ministry.
Awesome. Wonderful.
Now, spiritually?
Yes.
Want to know that?
Yes. That's the best. We save the best for last.
Absolutely. So spiritually, I am overjoyed to sit here with you and be able to say that I'm broken open now and no longer wear a mask, but I did for many years.
Broken open.
But I'm a human. I'm daughter of the King.
Amen.
And so are you, my sister.
Amen.
and you know, those were sort of empty words that I kind of would hear and say before, but I embrace that now, and I really believe it. I know that I'm beloved, and today I think spiritually I live in expectation and anticipation of God's work, both in my personal life and in the life of my profession.
Two key words: expectation and anticipation. We can go off into a whole nother topic, but
we can indeed.
Thank you. So I wanted to go back to when you founded Drug Free Duval, and why? Can you kind of share with us the backstory behind that?
Sure. In 2008, I happened to have woken up real early in the morning. I actually did a lot of my work before the kids would get up.
Right.
And I'd woken up 4:30 or 5 and was standing with a cup of coffee, watching my tiny little TV in the kitchen, just kind of catching up with the world.
You do that too?
Just to see, what kind of news was breaking. And there was actually a breaking news story here in Jacksonville about a young 15-year-old woman who had just been found on the beach pier. And the jogger who had found her thought that she was actually dead. She wasn't, but she was very, very drunk and passed out. And as she kind of came to, of course, he called 911, and that's how the news story broke. And she claimed that she had been sexually abused by multiple people because of this evening of partying. And I watched the couple things happened. The first thing that happened is I watched as the news story continued to unfold the rest of the morning. I watched it get shaped. I watched the words get shaped. Initially she said I was gang raped. A little bit later it was multiple sexual partners. By the 7 o'clock news, when everyone was awake, it was perhaps had a sexual encounter. It had been
so minimizing.
Oh yes, the words were minimized as the morning went on, and that I noticed that. Later, I found out that the place where she had been was at family that I knew who loved their children. They're good people, but they had been upstairs of their beach house and felt like the kids were safe because they were downstairs in their own home, and wanted to give them their space and that kind of thing. And so, honestly, it could have been my kids. And I wasn't angry. I wasn't judgmental. It made me say, why it could have been my kids. It could have been my home. What are we doing wrong? What do we need to do to engage in a different way? And I had never up to that point been involved in any social services.
Had not even an inkling.
No.
Or an unction.
Not at all. And everything that I had done to date had been either mostly business with a little bit of the political stuff thrown in. So I really didn't know how to go about this. I went to a women's networking group and brought the question up and just said, I'm so troubled. We've got to do something. Well, it ended up there was this tiny little grant in the state of Florida. It was called the Strategic Prevention Framework State Incentive Grant. We lovingly called it the SPIFSIG. And it was a 5-year grant. We were in year 3 of the 5 years, and Jacksonville had not gotten their share of the money because there wasn't anybody here to actually start the coalition. So this little group of women and I said, we'll do it, knowing nothing about anything. And we engaged a very fascinating process. This methodology basically says you start in your own community, and it's a data-driven process that you start with consequences, look at the behaviors that are linked to those consequences, look at the whys and the why here's, like attitudes, retail access, whatever it happens to be, all data-driven. And then what is our capacity, our readiness for change as a community, and then what is our strategic plan to change it? So it was a very business application to a social issue, and which was good because I didn't know anything about dealing with social issues at that point, and made a lot of sense to me. So we actually got the grant. It was only $30,000 a year. So once we got it and did our bylaws and all that stuff, everybody said, well, you need to run the company. And I said, no. I can't do this. But I did. And here we are 9 years later.
So never say no.
That's right.
So let me ask you a question, Susan. That was the thing that got you involved in wanting to make a difference. You were burdened by what you had seen. So now that you've been running the organization, what kind of encounters have you come across? Because I know not just in the media today, it's been a chronic issue, but it's just now coming to light. They're putting a flashlight on it about how misuse of opiates to deal with trauma or chronic pain is becoming an issue. And so from what you've encountered, how did that
happen?
Happen.
It's really kind of a perfect storm. In the late 90s, the FDA changed the use of opioids. Up until that time, they were only for not chronic or not acute pain. It was really for in-term life, terminal illness.
Okay.
So it could be in-term AIDS, cancer, things like that. That's when opioids were issued, because they've been around a long time.
Right.
So the first thing they did is say opioids can be used for any pain. So you could use it for tennis elbow, or you could use it for a sprained ankle, or you could,
Really?
At the same time, it wasn't even a real study. There was a letter written by two physicians at a New York hospital that had for about a year studied opioid use for acute pain in the ER, which was very different. It's just in the ER.
Right.
And they had said, hey, this is really effective for acute pain in the ER when you have somebody with a broken arm or, whatever.
Right.
And it's not addictive. It was just an opinion. There had been no real FDA study done around this.
Wow.
So the pharma companies basically marketed and said, hey, it's not addictive. See, we have this letter from these doctors. And the third issue that happened is there was a study about how people heal more quickly and more effectively when their pain is managed.
Okay.
So that was kind of the third factor. Then about a couple years later, there's something called JCAHO, which is the Joint Health. Basically, it's a group of folks who make the parameters for which Medicare is paid, for hospital ratings, for all that kind of stuff. And JCAHO came out and said the fifth vital sign is now going to be pain. The other vital signs are like your oxygenation level, your heart rate, these various things that are very finitely measured, and they're not subjective. They're objective.
Okay.
Pain's objective. So, if there are 5 people and they all had the exact same injury, they experience pain in different ways.
Levels of pain. Right.
Exactly. So those perfect storm elements all occurred at the same time, and opioids went gangbusters. The sale went gangbusters. So this was now the early to 2000 to 2004 or so. Well, within 3 to 5 years, we had lots of opioid addicts, and people that in the beginning were saying, oh, thank God, I've had this chronic back pain and it's been wonderful. So we began to see this. We had formed the coalition in 2008. We began to see really early numbers of increases that were frightening. They were still very small, but we'd see an increase from misuse of opioids from maybe 1% of our population to 5%, which is tiny. It's still only 5%. When you have 40% of people who misuse alcohol, 5% doesn't seem like much, but it was the trajectory. Okay. And so people around the country like us were starting to cry the alarm, but nobody really listened.
Because it was financially?
I believe there was a huge financial, physicians were partially not only scored, but also reimbursed based on their ability to manage somebody's pain. So it was easy to just give out opioids.
It was profitable.
Yes. And it was profitable, obviously, for the pharma companies. And
So with that being said, when I'm sure your organization, when they encounter individuals that have chronic pain, and then it becomes evident that even though they have chronic pain and it's being managed, it has now turned over into overuse and addiction. 1, how do you identify that? And then 2, how do you help them to learn to manage the pain and find that balance between using the opioids and using other alternatives?
That is a great question. And so right now, what we need to do is folks that have been on opioids for a long time, you can't just ask them to stop.
Right.
Folks that are already prescribed and using regularly opioids for chronic pain, we're not going to, it would be cruel and unusual punishment.
Turkey, right?
Yes, we're not going to do that. And, that's a hard decision and work that they need to do with their individual physician. We don't advocate for that. We want, but at the same time, we hope that their physicians are getting more education. So that's one of the things that we're doing is we're providing education to both the consumer, the patient, and the physician. And we're hoping that those physicians will begin to incorporate some creative and additional modalities, things like acupuncture, even mindfulness, and learning to move into the present.
That's big now, mindfulness.
And it is incredibly effective. We have things like battlefield acupuncture that we've mentioned, which is highly effective, just shockingly effective. So
I haven't tried it yet, but I'm actually slotted to try the battlefield acupuncture. Yes.
I'm so excited. I hope it's effective for you.
Me too.
Yeah. And if that is effective, because what we're doing now is testing it in the VA and some acute areas like that. If it's effective, it should roll out all over this nation.
Wow.
It's inexpensive. It's effective. It's, if it's effective roughly 75% of the time right now is what the early studies are telling us. So even talk therapy, and when I say talk therapy, I don't mean with a therapist. I mean a facilitated group of people who simply can get together and talk about how hard it is to live with pain. That
managing the pain.
Yes, it is actually showing to decrease people's pain. So people that are currently on opioids and aren't being asked to get off, if they can meet with a group of people every couple of weeks and say, wow, I encountered this and I wasn't able to pick up my daughter from school and I'm so tired of being on this stuff. They tend to take less opioids over the next couple weeks. So there's fantastic stuff going on and opportunities for folks who are already taking a lot. Now, on the prevention side, we're providing massive community education for everything from what opioids are, signs and symptoms of misuse or abuse, how to safely store and how to safely dispose, and then naloxone and Narcan education, which is the reversal drug if somebody does overdose. We provide that liberally all over our community. We have, and it's not my little organization. I only have 3 employees. What we do is we partner with tons of organizations. So we have over 40.
Collaborative.
Oh, it's amazing. So currently we have over 40 community trainers that come from all kinds of agencies and organizations, and they have to get certified. And we have 40 more scheduled to train. So we'll have 80 trainers in our community that will go out all over the place and provide this training.
Okay, so you will go out to organizations and colleges and churches and whoever wants the education.
We'd go to a sports organization.
Do you do
homeowners associations?
Okay, so do you do like individual families and stuff like that, or is that something?
We probably have enough people that we would. If somebody needs it, we'll figure it out. We will provide it. And the exciting thing is this is kind of spreading across the country. At the same time, we're training physicians. Again, we kind of want, for lack of a better concept, we want everybody to rethink pain. We want us to, instead of trying to stay pain-free and seeking pain-free, we want to shift the concept to managing your pain.
So when speaking of opioid use for managing chronic pain, can you share, like, since you've been interacting with different organizations and trying to kind of change that trend, have you seen a shift in the amount or the number of cases you have of overuse or addiction, or has there been a way to track that?
That's a really good question. I would say right now we have not seen the top. And basically because the numbers in treatment specifically for opioid abuse or misuse or addiction continue to rise. Now it is leveling a little bit. Our overdoses, and that's a whole nother class of folks who are addicted. And, an addiction moves beyond just treating the physical pain. It moves into treating emotional pain.
Psychological,
Exactly. And so our overdoses are continuing to rise here in Jacksonville. We had 39 last month. 39 overdose deaths. That was overdose
So
deaths.
That's not even counting the overdoses that didn't result in death.
Exactly. Over 400 overdoses with 39 deaths.
In 1 month?
In 1 month in Jacksonville, Florida. In one little city.
Oh my goodness.
Yes.
So what would that look like? Like, say, and then there's a person out there in my listening audience that's listening. They have chronic pain. They're struggling with it. They may be using a mixture of therapies, maybe, other things in addition to the opioids or opiates. What would that look like for them if they don't know, if they don't feel like they're addicted, or if they don't feel like they're heading towards overdose? What would that look like? What are some of the symptoms, the signs that they can use to identify?
If they're using their drug off-label, and what that means is if the doctor has prescribed it, the physician says 4 times a day, a certain milligram, right? 4 times a day, and they're maintaining that, and they can function, and they can, live a normal life. Maybe not drive, but everything else but driving, they're fine. If they are taking more pills than what they're supposed to, if they are mixing other pills with it, and I'm not talking about like there are really exciting things happening where people, physicians will now prescribe and say, go ahead and take your hydrocodone, and then 4 hours later take an ibuprofen, and then 4 hours later a hydrocodone. That's fine. You're mixing a drug there, but it's actually reducing the amount of hydrocodone you're taking.
Right.
So that's fine. That's not an addiction. You're okay. When you begin to need more medicine, when you never can find the pain relief, you need to talk to somebody. You need to talk to your doctor. You need to talk to to the nurse. Let them know what's going on, and they'll help figure out some alternatives for you.
Okay. So for not say the person that's actually managing their pain with opioids, for a family member or a loved one that maybe is identifying and they are still in denial, what would you say to that family member or that loved one as far as how they can get them to come to the realization that they are mismanaging?
It's really, really tough. It's a very, very hard thing. I'd say lots of prayer.
Yeah.
Seriously. But in addition to prayer, I would say make it your business to go to the physician with your parent or friend or family member, whomever it is. Be honest with them. Be really, really honest. When you go to the physician, make sure that they take their actual bottles of pills, and I would never be rude or angry, but I would just say, I just want to, have you realized that you're actually taking 2 pills at noon instead of 1? Doc, is that appropriate? Because your bottle says 1, it's a hard thing to do. There is help. There's help out there, but it's really hard to do.
Okay. And one of the reasons I asked that, and one of the reasons this is so near and dear to me as well, is because of some issues and things that I was encountering. There was a point in time where I was on many meds to manage not just chronic physical pain, but emotional pain, to the point that at one point in time I was on maybe about 30 different meds. But it changed my personality.
Absolutely.
It changed my ability, my drive, to want to do things. And I was stuck in that place, and I didn't know how to get out, and I didn't know, who to share it with without feeling the shame or the condemnation or the guilt that's attached to that. And it took me some years to come up out of that. And then I began to do the research myself. And this is one of the things I want you to touch on too, helping someone that is struggling to learn to become their own advocate and knowing their bodies. Because when I began to do the research, I found that some of the meds that I were taking were interacting adversely with the other meds and causing additional symptoms or additional issues. And so, what would you say to a person that was in that predicament?
Well, first let me touch on the mixture of meds. And there's something that's kind of catching fire around the United States, and it's called a prescription drug monitoring program.
Okay.
And the goal of a prescription drug monitoring program is that a physician then is more educated, because if a patient comes and says, my knee really hurts and I need, and the physician thinks this is the only time that the person has been seen and, whatever, and they prescribe a certain thing, they may not have any idea that the patient is on 3 or 4 or 10 or 20 other medications that might, as you said, negatively interact.
Right.
So prescription drug monitoring allows that physician to pull up by computer in real time any prescriptions that have been prescribed over the last year for that patient.
Okay. So they're kind of intersecting now.
Yeah.
Intercepting.
Yeah.
Okay.
So in the state of Florida, we did pass a PDMP. Ours is called E-Force in Florida, but they have different names all over the world. But PDMP is actually, or Prescription Drug Monitoring Program. It gives the physician additional information. So the first thing that a physician should do is if he pulls the PDMP and he sees some other drugs, he should stop.
Okay.
He should stop and sit down and say, what's really going on here? So if you're taking, benzos and you're taking some amphetamines and you're taking a couple other pain meds, and now you're coming to me with a pain situation, and this is part of the physician education we're providing.
Okay.
First of all, you got to know drug interactions, but in addition, you have to look deeper than just the physical pain, which might be real, but you have to look deeper than the physical pain and help that patient get a whole health approach to solving this issue, because they probably need a mental health person, an addiction specialist, and the pain doc to all work together as a team.
So it's a holistic approach.
It's a holistic approach.
Okay.
Beyond a shadow of a doubt.
Okay. So studies have shown that young people who start out with heroin make the switch to more powerful opiates like fentanyl. How do we curtail the problem where young people are prescribed opiates for pain management more frequently?
That is the goal of what we are working on. And I will tell you that just yesterday, the governor of the state of Florida announced that he is proposing legislation that will limit new opioid prescriptions to 3 days.
Really?
Which is what Europe basically has.
Okay.
Europe typically is 3, no more than 5. Our problem here is that we give a 90-day prescription.
Okay.
Somebody gets a tooth pulled and they get 90 days of oxys.
Let's see, I'm learning something new every day.
Which is where the addiction can happen.
For tooth extracts?
Yes, and the problem is because your physical pain, initially it treats physical pain.
Right.
The pain receptors that the opioid sits in, it doesn't know if it's physical pain or emotional pain. So here's a way addiction happens. So I get a legitimate prescription because I tore my meniscus in my knee, and I get a little surgery, and so they give me medication. So 2 weeks later, I'm not hurting anymore.
Right.
I'm not hurting, and my prescription's sitting up there. I'm back at work. Life's going good. And I come home one day and I've got just a headache. And I go, that opioid really worked well for my knee. I think I'll just pop one for my headache. So you get
used to that feeling. You're looking for that feeling again.
Well, then a couple weeks after that, I've had a fight with my spouse. And I'm not feeling so good. And I go to open the cabinet and there's that opioid sitting there. Because remember, I was prescribed 90.
Right.
So now I take the opioid for the emotional pain and I feel good. This is addiction. It's the start of addiction. If you are taking the drug and you no longer have physical pain, although when you're addicted, oftentimes you fool yourself that there is physical pain.
Right.
But it's really treating the emotional pain. So the question about heroin and, people are not prescribed heroin per se, but they are prescribed opioids. And so people will quickly switch to heroin as a street drug. And the problem is fentanyl, which is 50 to 100 times more potent than heroin. It used to be extremely rare to find on the street. It used to be something, it's a prescribed drug. Well, it's typically used in a surgery setting.
Okay.
It's one of the mix when you are literally put out,
right.
And you're being monitored by an anesthesiologist,
right.
et cetera. So and now there are fentanyl patches. Have you seen, there's fentanyl patches. Occasionally when a person has a really bad, like a torn rotator cuff or something, they might give them a fentanyl patch. Although I really wish that we do away with them because an addict will scrape the gel out. It's supposed to be a 24-hour patch and they'll scrape the gel out and take the whole thing in one setting. Yeah. So we're just trying to enact legislation that will limit the number of opioids. This is not our current users. Like I said, I don't want to create panic with people that have chronic bad pain. Right. But with new users, which oftentimes are youth because they've...
A fentanyl patch.
Yeah.
Dang. That's like, I'm sorry. I'm used to just like being quiet and not saying anything. But
right.
That's crazy. And
for my listening audience, we all know who this is.
That's like a nicotine patch, like to the exponential power of 1,000,000.
Absolutely.
That's crazy.
Absolutely.
And they scoop the gel out of the patch.
Yeah. An addict will. Not if a person's using it correctly, they wouldn't do that. Yeah.
Wow.
So that they've just become overtaken by the need to have that high.
Right. And fentanyl is so incredibly potent that it takes an opioid or heroin user to a new level of high. And then they crave that level of high. So
what are the long-term effects of using the opioids? And, aside from death, I mean, that's but I guess some markers or some indicators that you could use to identify.
Well, if there are chronic pain users that have been on opioids for a really long time that have used them very effectively, it is really now contraindicated for chronic pain to prescribe opioids in the new way of thinking. Again, I don't want to scare people that are currently on it. Work with your doc. Nobody's going to take your medication away that you need. But if you're using it incorrectly, oh goodness, there's an effect on your heart, on your kidneys.
That's what I wanted you to bring out. Yeah,
absolutely. We have a cardiac doctor who is on our task force who says that he sees 19 and 20-year-old young people who have the heart of 80-year-olds because of chronic heroin and fentanyl use.
Wow.
Kidneys the same way. They're seeing young people put on dialysis at 25 and 26 years of age. These drugs are tremendously hard on the rest of your body.
And for my listening audience, again, I didn't want Susan to share this to instill fear. This is all about education and finding other preventive methods to manage chronic pain and just be able to have the most informed information so you can make an informed decision when you're dealing with your loved ones or your family members or even yourself.
Well, there's that saying, you know better, so do better.
Right.
So we really didn't know better 2 years and 10 years and 20 years ago, but we know better now. So let's do better.
Yes.
We don't need to have judgment or recrimination or anger, but let's move forward. The JCO that I mentioned has now taken the financial reward to pain management away. So the financial reward for physicians and hospitals related to pain management has disappeared.
Awesome.
But the judgment as to whether you're a worthy institution is still on the table. We're pushing for that to be removed too.
Okay.
So if there's no incentive to
there you go. That kills the incentive for the doctors to actually go ahead and prescribe it.
Exactly.
Right.
So that is a big step. And that just happened in July, the financial side.
I was reading something because my wife does this. She does this pain management, like drug interaction, crazy stuff.
Yes.
And I was reading something in one of her books the other night. They were talking about the psychosomatic effects of heroin addiction. And what I thought was really interesting, you had just touched on this. A lot of people think that because you're a heroin addict, it has the same effect on your brain like marijuana does. And it doesn't.
It doesn't.
It actually has almost zero effect on the brain cell count of the brain itself. What it does do is it does a wrecking ball job on your internal organs, though, because heroin over time affects your mental capacity in terms of being able to your tolerance.
Exactly.
Your tolerance for things.
Absolutely.
And I just kind of wanted to put that out there just to, make sure that, I was on track with that. I didn't want to walk around with, this crazy idea that, I can self-diagnose somebody that's a heroin addict. Wrong answer. Don't do it.
Right.
Get professional help.
Right.
Exactly. Completely agree.
Okay.
So opioids to me are like guns being handed out to patients on suicide watch. I believe that opioid addiction has definitely made epidemic worse, but I don't think they are the underlying cause of depression. But in fact, it is more related to life issues like unexpected pregnancies, loss of job, lack of fulfilling careers, or life situations. So ultimately, how do you address the real issues of depression that may trigger the addiction?
That is a really great question. Have you guys ever heard about the Skinner box versus the Alexander, the rat park?
I have not.
Well, the original studies on whether a drug itself was addictive or not was to put a rat in a box by itself. And the rat had water, and then it had water with the drug. Mm-hmm. And so quickly, the rat by itself in a box would learn, oh, if I push that one, I feel good. And rats would literally, depending on the drug, punch that little water with the drug so much, even to the point of death. Okay.
Wow.
So one day, this was the early, and they began to identify drugs and say, oh, well, this drug is definitely addictive because the rat will go for that over and over and over.
Killing itself.
Yeah, even to the point of killing itself. Well, then a researcher named Alexander in the mid-'80s came along and said, wait a minute. We put these rats alone. Rats are pack animals by nature. What if we put a whole bunch of rats together? So he built what was called Rat Park. And it was a big cage, and it had lots of little cans and things for rats to do, you know, some grass around and stuff. And he put 20 rats in there. And so they put water and water with cocaine, water and water with heroin, and water and water. Lo and behold, the rats did not go for the drugs.
Really?
No. Then they even sweetened the water. They still didn't go for the... Well, they did until they realized they would get high. They stopped. So they'd try it. It was good. I promise you can look this up. Oh. So the only time they would go for the...
You know I'm looking it up.
I know you are. The only time... Alexander Rat Park. Look it up. So the only time they would go for the water with the drug in it is if it was actually neutralized with something like naloxone. With heroin, you know, if you put naloxone, it would neutralize the drug. So the conclusion is, wow, environment was different.
Right.
And socialization was different. So the problem is, how do you test that on humans? You can't put humans into a big, you know. But what Alexander did is he began to look around history, and he identified, and there are many researchers who agree with him, the Vietnam War was sort of a picture because you're taking us humans out of our social environment that we know. You're putting us into somewhat of isolation. If you know this, heroin addiction for our soldiers over there was higher than any addiction we've ever seen during a war. And yet when those folks came back, roughly 5% continued to battle the addiction. So even though 25 to 30% were actually addicted or using regularly the 21 days or more, over in Vietnam, when they came back to the United States, they were back in their social environment, they were back in their support system, the better environment, and they quit using heroin. So this begs the question, depression, I mean, obviously there is depression that is chemical. There's depression. You must be diagnosed by a professional because you might need an appropriate medication. It's not going to be heroin, but you might need an appropriate medication to help balance your chemistry. But you also need community.
Yes.
You need healthy, thriving community that loves you. We are wired for bonding.
We are wired for companionship.
Yes, we are.
So, with you saying that...
Are you reading it?
Yeah. Okay, hold on. All right. I got to jump in here. I'm reading this. So, here's the part that I got out of it. And actually, you just summed it up with that last statement. So, they showed a statistically... Talking about the rats. They showed a statistically significant preference for the plain water. He writes that the most interesting group was group CP. That's the control group. The rats who were brought up in cages but moved over to Rat Park before the experiment began. These animals rejected the morphine solution when it was stronger, but as it became sweeter and more dilute, they began to drink it. But they were together. So the conclusion is that as long they wanted the sweet water, as long as it didn't disrupt their normal social behavior. Right. And because we are wired to be around people, that's why you get folks that you get prisoners that are put in isolation. They go nutso after a point in time because we as people, we're built to be around other people. And I think that's so cool. That's amazing to me that the main deal to get to beating the heroin addiction is to be around folk, to be in surroundings that are familiar to you, to be around people that you know.
That are in, connected
that
relationships.
Are connected with you.
So that leads to the question, for those that battle with chronic pain management, are they really taking the meds to battle with that pain, or are they taking it to alleviate the loneliness and the ache of not being connected by community or, having a network? And so that pain then becomes emotional, psychological, but then that medicine is the buffer to not feel.
Well, and look at some of our highest use of opioids, chronic users, elderly, which obviously elderly people are experiencing more pain, but they're also one of our very most isolated groups of people. So, and the highest new use and it's an exploding level of overdoses is in our 50 to 69 year olds.
Wow.
50 to 69. Interestingly, this particular drug is not as highly, our number one overdose age in Jacksonville is 25 to 29.
25 to 29.
25 to 29, then 30 to 39, then 40 to 49, then 50 to 59, then teens. And we have fabulous statistics. We literally can track the time of day they overdose, what zip code they live in, what zip code they overdose in, which hospital they're transported to. So we have extremely excellent data. So
that is just validation for the need for community, the need for connection, the need for a support system.
And think about how, if we really embrace this, it could drive public policy, things like housing. Because if we understand, which often are riddled, we all go, I don't want the housing in my neighborhood because there's drugs and there's this and that. Well, maybe those folks are craving connection.
Yes.
So if we redesign how we create public housing to encourage and support healthy connection and health, everything from walkability to regular medical care to, sharing child care and things like that, and community, having an opportunity to eat together, we could dramatically change drug use in America.
I believe we can do it.
Isn't that crazy? It's exciting.
What that really means is that you have to build in a sense of accountability and have the community accountable to each other. And that's not an easy thing to do.
It's not. It's a huge paradigm shift.
It is.
It is.
So,
but are we brave and bold?
Yes, we are.
Let's do it.
So what's the first step in being able to create that kind of environment?
That's a really good question. And I would venture to say that we're beginning to see a few things. Today I had a visit by somebody from the city of Jacksonville, and it was really related to a strategy that we're trying to employ to help parents understand the best way to talk to their kids about specifically opioids. But that led into us talking about partnering some of the education in some of the existing programs. So basically we're talking about cross-collateralizing various organizations, entities, and stuff that the city hasn't really been thinking about yet. Well, then the city officer actually contacted me this afternoon and said, we're really excited about a couple of these things, and we want to go ahead and bring in the faith-based community. And so we have a faith-based strategy that we think is going to work. And so I was able to say, well, there's some other faith-based strategies that you probably don't know about. So let's try to put them all together. So I guess what I'm saying is I see these efforts beginning in a fledgling way. And honestly, if we could get preconceived ideas out of the way, I think we could really do some amazing things.
When we get preconceived ideas out of the way. And, that do not despise small beginnings. I just feel that this is cutting edge.
It is.
Way of how to bridge the gap. Because
and just you even allowing us to talk like this.
Right. Because we have to talk about it. Because if you hide it, you can't heal it.
That's right.
I'm just thinking about mental illness and how that correlates with drug use.
It's huge.
Overuse of drugs. Because, again, you're alleviating the pain of dealing with feeling unconnected. Because you can be surrounded by people and still not be connected and still feel alone and still feel unattached. And then it becomes easier to just use that drug of choice, that prescribed drug of choice to not feel the pain, to feel good, to feel numb.
Yeah.
So you don't feel that. So
there's such a stigma around both mental health issues and substance abuse struggles. And we need to just understand that we call it brain pain. You know, just like you have heart pain or you have knee pain, you have brain pain. Literally, we can now see that. We can see with brain studies, your brain's in pain. And so when you add something that takes away the pain and it sits on that receptor, your brain doesn't feel pain anymore. So just like with your knee, and there'd be a healthy way to treat your knee, but there'd be an unhealthy way to treat your knee. An unhealthy way would be to go out and get wasted so you couldn't feel your knee, right? The healthy
that would cause other issues.
Exactly. The healthy way to treat your knee would be to potentially get surgery or physical therapy or wear a brace for a while. There's many ways, and it's the same with brain pain. You know, we have to understand that it doesn't make you an evil person or awkward in society or outside of the rest of us. We all have struggles, and mental health issues and substance abuse are just another issue. And once we destigmatize and can openly talk about these things and seek really crazy, awesome solutions,
we just need to do away with the titles and the labels, because mental illness doesn't have a face. You know, as they try, as media and society tries to place a face on it of what it looks like.
Right.
You know, drug addicts don't have a face.
No, they don't.
It could be me. It could be you. It could be that top level executive. It could be the pastor that's silently battling with, you know, drug addiction.
I will give you an interesting thing to Google.
Yes.
Here's a couple things. The first one would be heroin use, daily heroin use by executives. If you Google that, you'll end up on a couple of forums, Blue Light and a couple other places that will openly talk about, I'm an executive. You don't know what company, but I'm an executive and I use heroin daily. It's fine. It's totally under control. And the next person might say, I did for 5 or 6 years. It started to get the best of me. So, you know, it's amazing. I started thinking, okay, so I can be meeting with a bank president and he might be on heroin, you know, and he could be. So to your point, another one that is very interesting, I know it's a little off topic, but it does deal with drugs.
It's all related.
Google bad marijuana highs. Bad marijuana highs. And what you'll see are people talking about a really bad high that they had while on marijuana. And these are, you can read through them because they're all individual, but many of them are very chronic marijuana users, people that use weed daily, you know, or twice a day, and they just get some bad pot. And when they describe their bad high, much of that pot that's bad today is laced with fentanyl. That is something I'd really like to mention, that we are seeing cocaine laced with fentanyl, marijuana laced with fentanyl, obviously any of the synthetic oxys and hydros laced with fentanyl, and then pure fentanyl on the street. And a lot of times people don't even know. They're a regular marijuana user. They're not intending to use fentanyl, and they go buy marijuana and it has some fentanyl in it and they overdose and die because they had no idea. And they don't know how to use fentanyl. So we need to be really aware of this drug and be very careful of it.
And what comes to mind as we're talking is the driving force behind using the opioids or the drug of choice is pain, but it's also loneliness and the desire to feel good. And so we're willing to sacrifice everything just to not feel that crushing loneliness or depression or whatever it may be. And the physical pain is then probably exasperated because...
Exactly.
So how do we begin to change that? Because with today's society, with technology and Facebook and texting and, you know, it kind of detracts from being able to, relationships and being able to interact or even feel comfortable interacting.
It's interesting you say that because I have 4 kids. And so my youngest has grown up the most recently with my kids all text and all that, but my other 3 really just text functionally. They'll text to say, are you at the restaurant yet?
Right.
You know, save us 5 seats, something like that. My youngest is really more comfortable having text conversations than face to face. And we are praying about that. We are trying to help him understand that, put the phone down, talk human to human. But even his friends, they'll sit in a room together and text across the room.
And that's we've had that conversation, because that's almost an addiction in and of itself.
Beyond a shadow of a doubt. Totally agree with you. Yeah. And really, the crazy thing is we're learning that your brain releases dopamine and things like that. As a matter of fact, I'm going to tell you something crazy. These are very, very new studies. But if a person has anxiety, diagnosed anxiety, which is a real mental illness, so they have diagnosed anxiety, but they're not treated. So a person with anxiety will typically worry. When you worry, guess what? Your brain releases dopamine. When your brain releases dopamine, you feel good, even though you may not feel great, but your brain, remember your brain's in pain, so it's in a little less pain in that moment. So, but you've just worried. So when you worry, you have more anxiety. So when you have anxiety and you worry, dopamine release, you worry. Anxiety, dopamine release, you worry. You are literally locked in this loop, you're almost addicted to worry. And don't you guys, have you ever experienced a time in your own life where you just couldn't get out of kind of a worry cycle? Well, your brain was actually giving you some dopamine, so you didn't know it. And, the Bible tells us to think on things that are pure and holy and righteous.
And good virtue.
The Bible tells us to be transformed by the renewal of our mind, not conform to the world. Those are all things that I think God was telling us, don't get into this loop. You can be in this loop of anxiety. Same with depression. So if a person is depressed and makes the decision to stay in bed, their brain releases a little dopamine. It's probably my phone. My husband.
Hi, you're on the air.
Hi, honey.
So for my listening audience, I know it may sound like we are going off topic, but really we are not. Don't apologize. It's all connected. It's all related. And so if you begin to deal with the issue, the underlying issues under the chronic pain, then you'll be able to alleviate or minimize your need to use opioids.
The best treatment that we've been able to see in terms of helping folks who really are addicted to opioids or heroin involves a longer term treatment, which think about this. So you're putting somebody into a safe environment now for an extended period of time away from the habits of their use, right? And you couple it with a peer mentor. A peer mentor, a person who's been through what they've been through, and they're there, they speak the same language. As a matter of fact, one of the peer mentors that I just have learned so much from, he said, we speak the language of the heart to each other. They understand each other's pain. And they're able to help heal. They can take their hand and walk them down a path toward that emotional healing, which coupled with, there's a physical component too. I'm not reducing the physical component, but that's the most incredibly successful treatment that we see, which go back, we're dealing with that emotional pain. We're dealing, and of course, if there's physical pain, that's being dealt with also. But it's just an amazing picture. And you're right. You're exactly right, Michelle. It really boils down to the hurt, the pain, dealing with it with honesty, facing it, not running away from it. The more that we run away from it, just like like you say, if we run away from it, we can't fix it. You can't fix what you hide.
If you hide it, you can't heal it. And I'm just going to be very transparent here for a moment. The reason that Michelle Speaks even exists is because as a society, we've become so accustomed to wearing masks and hiding things. And, I was diagnosed with anxiety, depression, major depressive disorder, agoraphobia.
Were you really?
Yes. But that is why I want to be so transparent, and I want people to know that mental illness does not have a face. Chronic drug use or for pain management does not have a face. There is hope and there is healing. We just have to be brave enough to know that there are other alternatives, and there are sources and resources out there available to you if you will just take that first step.
Absolutely.
If you would just take that first step to begin the journey to healing. And so I just want you in a few moments to talk about our listening audience, where they can go to get the help, how they can contact you, a takeaway for our audience and a call to action for someone that's listening in that's struggling.
In most of the communities around the United States of America, there is a phone number, a 211, which you can call to at least get plugged into what resources are in your community. Here in Jacksonville, and if you reach out to us from anywhere in the country or even even in the world, we'll find help for you. So if you come to our website, www.drugfree.org.
Okay.
drugfreeduval.org. Sorry.
That's okay.
It's been a long night.
Right.
Drugfreeduval.org. Then we will hook you up. You can send an email to info@drugfreeduval.org or to Sally. That's not me, but she's this amazing connector.
Right. She is.
Yeah.
She is.
Sally at drugfreeduval.org, and we will get you hooked up. We have contacts all over the United States of America. We work directly with NIDA, which is the National Institute of Drug Abuse. I'm speaking on a panel at Johns Hopkins in October.
Awesome.
Yeah, we work all over the country on we don't provide services all over the country, but we're connected with folks all over the country. So the call to action would be, to me, the first thing is, don't be afraid of pain. If you're currently already involved in chronic pain management using opioids, be open and honest with your physicians. Don't hide anything. Let your family members in. Let them know what you're really doing. If you aren't currently using if you're not currently using opioids and something happens, you break your arm, something happens, tell the emergency room physician that you don't want Dilaudid, that you want something other than that. You don't want a narcotic.
So be your advocate.
Be your own advocate strongly and boldly. And they will find other ways. They will find other ways. And I'm going to tell you something. The other ways are better. If your doctor says, well, here's 30 days of hydrocodone, you don't have to fill that. You do not have to fill that. You can say, I'm going to wait and see. You've got the prescription, but you don't have to fill it. I would encourage you to give it 24 hours.
Okay.
If a doctor says to you things like, stay ahead of your pain, as an advocate for yourself, I'd say, no, that's wrong thinking.
Right.
No, I'm not going to stay ahead of my pain. I'm going to feel my pain and let it be appropriate. If it hurts too much, as a matter of fact, when my son had foot surgery, we gave him 2 ibuprofen after the surgery, a couple hours after.
Right.
He got into a little bit of pain. We gave him half of a pain pill and said, we'll give it 30 minutes or so. And he said, no, I'm okay just with this.
Good.
So we stopped there. Be your own advocate and work on your medications that way.
So I want you to just give a word of encouragement to someone in our listening audience that may be on the brink of maybe ending their life because they're tired of the pain and they're tired of the addiction, but they feel there's no way out. What would you say to that person?
Well, Drug Free Duval's vision is freedom from substance abuse for all. And the reason we use that particular vision statement is because the opposite of freedom is bondage. And I understand if you're caught in this, that you are in bondage, but there is freedom for you.
Okay.
There is freedom calling. And all it takes is the first step. If you'll take the one step toward healing, and the step can be a phone call to the 211, it can be the email to us, it can be reaching out to a family member in honesty and letting them know how you're feeling.
Right.
There is hope. Am I allowed to talk about Jesus?
Of course.
Because the hope is Jesus.
He's the author and finisher of it all. So yes.
Absolutely.
Yes.
And it's not easy. I'm not going to say that you go, oh, Jesus, and you're healed. That does happen sometimes.
Right.
But he went first. He walked the path of pain for us. And the other side of that pain is our, not just salvation, but it's our freedom.
Yes. Yes. Thank you so much, Susan, for agreeing to come on and talk about this.
Thank you, Michelle. This has been an amazing privilege. Thank you.
Well, folks, there you have it. We've given you some information about opiates. We've given you some resources for those that are struggling or maybe fearful of opioid use. Hopefully, we've given you enough information for you to make informed decisions for yourself or for your friends and family and loved ones. So I want to thank you so much for listening to Michelle Speaks with me, your host, Michelle Portier. And we've been talking all about opioids with my very special guest and new dear friend this evening, Susan Pitman of Drug Free Duval. Susan, again, thank you so much for agreeing to share with our listening audience your experience and your expertise. Tune in to us every Thursday evening at 7 p.m. Eastern Standard Time. All of our shows are available in our podcast directory for free 24/7 by going to 180radionow.com/podcast or click on the podcast link in the menu on the homepage. Click the Michelle Speaks logo and you can access all of our previously aired shows. Download the 180 Radio Now app on Google Play and App Store. You can also listen directly on the 180radionow.com website by clicking the Listen Live button at the top of the homepage. Also, listen through your web browser on every major internet radio directory: iTunes Radio, TuneIn, Radio.com, Streema, Screamer Radio, and more. It is our sincere prayer that what you've heard this evening has blessed you and provided you with information you can use to help you in your situation or someone else's. Tune in again as we get to the heart of the matter, because if you hide it, you can't heal it.